So I'm going to share the presentation on Teams. I don't know how to stop the transcription, but I will allow that to work. Okay. Can you see the presentation now? Yeah.
Yep, can see it.
Okay, good. Just create some space. Okay, so today's teaching is about short protocol and long protocol. And this is just based on the ESHRE guideline. So I have not referred to any textbook. I thought it is better to discuss the guideline so we know that whatever I'm discussing today is evidence based and it is all picked up from the guideline. So this is from the ovulation induction guideline on the ESHRE website, which has been published in 2019. So if for future reference, anybody has any doubt or wants to do further reading on this topic, they are free to check the guideline. The guideline is roughly around 200 pages, but it has all possibilities and maybe if you want to go into more details, anyone can visit the guideline and find out more. So I have just condensed the discussion about explaining what happens with each protocol. I think many of you will know, so it may be a repetition or it may be something extra to know about the protocol. And we are going to discuss about why a particular protocol may sometimes be better, but we have segregated it into three types of patients: normal responders, high responders, and poor responders. So in each of these strata of patients, we will find out which protocol is better. And this is from evidence. So if you ask me the question why, then obviously they have done studies on thousands of patients where they have adopted different strategies, and then ESHRE has reached a consensus that this is a good practice point, or they reached a consensus that this is showing strong evidence. So that's how the guideline has been formulated. Okay. So when IVF started around say 40, 50 years back, that time the way they did the treatment was say with long protocol, because that was the protocol with the drugs which were available at that time. There was nothing called as a short protocol 40, 50 years ago, because there was no molecule called as GnRH antagonist. They had a molecule which was GnRH agonist. So that is why the protocol was devised as a long protocol where we use the GnRH agonist like how you have been using for your frozen cycles or your long protocol cycles. So most of the information about the protocol is gathered from time, because when it has been used for 30, 40, 50 years, that time they are able to study the embryos as well as the children who are born through the long protocol, and they have been able to study these individuals for many decades in their life to determine that the protocol has not had any adverse impact on their genetic makeup or on their well-being, or there has been no detrimental compared to any person who has conceived naturally. And that is why you deem that it is safe, because we know that we have so many years of evidence. Short protocol started on late in the 90s or early 20, early 2000 decade, where this molecule called as GnRH antagonist was discovered, and then they started devising protocols using the GnRH antagonist, and then now quite a few places it is the primary protocol which is used for treatment. So that is how the sequence of events have developed. Okay. Now, why was the GnRH antagonist now the protocol developed? So that's not because GnRH agonist protocol was poor, or it's not that there was something which was drastically wrong with the outcomes. It was working well, but obviously it used to take a longer time of for treatment, where you have to first switch off the ovary and then you start with a second dose of medication, a different medication. And there was certain there would be certain patients who would have had side effects with the agonist, like hot flushes and issues which may be undesirable for some. And it's always good to have a plan B. So with time, when the antagonist was found, they developed different protocols using the antagonist. So to understand how each protocol works, we need to understand the basics first. So I know the basics. Everybody would have learned, myself during my medical school, and the nursing staff when they did their nursing education. But I think it is always useful to visit this again, because this is the information from where we are going to decide how each protocol will work. So to discuss about the menstrual cycle, what happens in the first 3 days or the first few days of the cycle is the hypothalamus will release GnRH agonist. So there is the GnRH, naturally produced GnRH, which is going to be produced by the hypothalamus. The hypothalamus produces this in pulsatile fashion. That means every 3 to 5 minutes, it will release a pulse of this GnRH. This GnRH will go and act on receptors in the pituitary, and the pituitary gland will start producing this FSH and releasing the FSH in pulsatile fashion. So when there is no egg production taking place on the first 3 days, pulsatile release of GnRH will stimulate release of FSH. Now, because the GnRH is being released in a pulsatile fashion, like a drip feed, there is no overwhelming of GnRH receptors in the pituitary. So the pituitary receptors, it will bind, it will stimulate FSH, and the GnRH molecule will get destroyed. And so it is available to respond after another 3 minutes or 5 minutes for a fresh dose of GnRH agonist. So this is something which is happening in the background. And with this pulsatile release of FSH, there will be recruitment of follicles from the ovary to grow. So normally we see only one follicle growing after the 10th day, but in the background around 300, 400 follicles are being recruited with this natural FSH which is being released. So out of these 300, 400 follicles, for someone who has a normal egg reserve, one follicle, which is the dominant follicle, will start growing faster, and you will be able to see it on a scan when you start scanning from the 10th day onwards, or sometimes even earlier. So that follicle potentially has maximum number of FSH receptors, and that is why it has decided to grow, and the rest of the follicles have not grown. Some may be inside the ovary, but they are not even seen. And these follicles will be the ones which will perish at the end of the cycle, because they will not have grown during this month. So 400 follicles are lost each month, and that is how the egg reserve keeps going down. So every woman is born with a fixed reserve of eggs. So this is how the egg reserve is depleted over time. And the one follicle which is developing, now this follicle, what it does is it starts producing estrogen. So from the follicle, estrogen will start getting produced. So as the follicle increases in size, there is more and more estrogen which is being pumped out into the blood. And if, say, somebody has a 28-day cycle, in the middle of the cycle, we are expecting that this estrogen will reach a very high point, say in thousands or some numbers. I'm not saying what number, it will be different for everyone, but it will reach a high level where it will now trigger the release of luteinizing hormone from the pituitary. And the luteinizing hormone will be pumped up into the bloodstream in response to a very high level of estrogen, which has been produced by the dominant follicle when the follicle reaches an adequate size, say between 16 and 24 under ideal circumstances. And the LH, which has been released from the pituitary, will now go and hit the follicle which is ready, and ovulation will take place and the egg will be released. Okay. Now this estrogen, which was being produced for 14 days, was acting on the lining of the womb or the endometrium to cause proliferative changes in the endometrium to thicken it up, which is what you are seeing when we do this artificial cycle with giving estrogen. So it thickens up the lining of the womb. And once the LH has caused ovulation, the same follicle from where ovulation has taken place will change itself into a hormone producing gland called as corpus luteum, which is what we discuss about all the time. And this hormone producing gland is now starting to produce progesterone. So this progesterone, which is secreted by the corpus luteum, will start making secretory changes in the endometrium in the hope that there will be a fertilized embryo available for implantation in the endometrium at that point of time. So the role of progesterone is different. Now, once this progesterone production starts, it reaches a peak in 7 days after ovulation, by which time we would have hoped that implantation will have taken place with a day 7 embryo. And once the implantation has taken place with a day 7 embryo, which is say 7 days after ovulation, then the embryo which has implanted in the endometrium will start sending biochemical signals to the corpus luteum to continue secretion of progesterone for the future to maintain a pregnancy. If there is no embryo which has been implanted, this feedback or the mechanism or the sensitization or the molecular communication between the embryo and the corpus luteum doesn't happen, and that is where the progesterone level will now begin to fall if there was no pregnancy. And in a further 7 days, because the progesterone level has reached its lowest, the endometrium will be shed and there will be a period. So this is conclusive of there being no pregnancy in spite of ovulation. But if there was a pregnancy, the progesterone secretion will continue and pregnancy will be maintained with there being no period. The progesterone secretion from the corpus luteum will continue up to 9 weeks, 6 to 9 weeks. And after 9 weeks, the placenta will take over production of progesterone. So that is why the luteal support is given for 12 weeks. Ideally, it can be given only up to 9 weeks. So generally, 9 weeks is the critical turnover time where the placenta assumes production of progesterone. So technically, as per evidence, we don't need to give progesterone beyond 9 weeks. But that is the policy is to give it to 12 weeks so that there is an overlap in case there is any concern. So we also start that reducing the dose of progesterone as per the requirement, because the requirements are not there. That is why we are reducing the dose. And by 12 weeks, we wean off. So after 12 weeks, they won't require any progesterone for supplementation to support an embryo, because natural production is going to be enough. Placenta will produce n number of times. Okay. Now our long protocol and short protocol will all depend on this menstrual cycle. And what happens with the long protocol and what happens with the short protocol, we'll discuss now, how each one works and where there is a benefit and why there is a benefit with one particular protocol. So with the long protocol, the GnRH agonist is started on day 21, which is what we routinely do or we mechanically do. So some people may understand why it is done. Some people are doing it because it's a policy, it is a guideline, it is a protocol. So we follow it blindly. Okay, because that is what we do all the time. But so basically with a day 21, when we start with the GnRH agonist, what will the agonist do? This agonist is a drug. In this case, when you're using Buserelin, it works for 24 hours. And if you're using Prostap, it works for 28 days. So what this Buserelin will do is, now it will go and fix itself to the receptor in the pituitary, but it is not pulsatile in the sense the one from the hypothalamus is released every 2-3 minutes. But this is going to go and occupy that receptor continuously 24 hours for the next 24 hours, unless you don't give the medication the next day. But the GnRH action to begin with is to fix to the receptor and release the FSH, which is already formed. So on day 21, when you start with the GnRH, it will fix to the receptor and it will empty the pituitary of the FSH LH, which has been naturally produced and stored in the last 21 days. But because this drug is going to be given continuously every 24 hours in the form of buserelin or in the form of Prostab, where it stays, the molecule stays for 28 days and it sticks to this receptor for 28 days, there is going to be no new FSH and LH production happening in the pituitary, because this molecule is sitting there and making a home. I am staying there for 1 day, or I'm staying there for 28 days. I won't allow anything else. So if the molecule is staying there, there is down regulation of the receptors. The receptors will stop getting generated and there will be no new receptors forming. And the stimulation has already taken place. In the sense, the FSH-LH from the pituitary is emptied. And now there is no FSH-LH. If there is no FSH-LH, then there is no recruitment of follicles. There is no estrogen production. So what will happen is, when over a period of 2 weeks of giving the GnRH agonist, we would expect that the estrogen levels will fall into a menopausal range. So this is like medical menopause. So estrogen levels will fall into the menopausal range, and that is reflected indirectly by seeing an endometrium which is less than 4 millimeter. We would expect that the woman would have got a period in that time, and we would see in 2 weeks' time that the endometrium is thin, which means it is menopausal. Now, you may see that some patients, when we routinely do scans, we give GnRH agonist on day 21, and then you see on down regulation after 2 weeks. Now, here I am going off track because we are discussing clinical relevance. We are not discussing just the theory. So 2 weeks down the line, there will be a nurse who will come to me and say, Dr. C, there is this patient, we down-regulated her, but now see her endometrium is thick in 2 weeks' time. Instead of becoming thin, she has not got a period, and I am seeing 1 or 2 follicles on her ovary, and they were not seen on day 21. But now she is having some 20-24 millimeter follicle. Now what to do? So what has happened in this case is, this woman may not have ovulated, okay? May not have ovulated, like someone who has PCOS and who doesn't get a regular cycle, she will not have ovulated. But when you emptied the pituitary by giving the GnRH agonist, the primary function which happens immediately when you give the agonist is stimulation, which is release of FSH and LH from the pituitary. So that LH has increased growth of follicles from the ovary, and that has stopped her from getting a period, and that has resulted in cyst formation when you scan her in 2 weeks' time without having a period. Okay, because she, in this case, she has not responded, or she has responded because she has not ovulated. That is why we scan the patient and we only give the GnRH agonist once we confirm ovulation. If somebody has not ovulated by day 21, we will scan them in another 3-4 days to check if she has ovulated or not. But sometimes in some women, we may not see evidence of ovulation, which is not something which you can do anything differently about. We are going to assume that she has ovulated if we are not, even though we may not always see a corpus luteum. And there may be such situations which may arise in some patients, which may result in abandoning the cycle, or they requiring GnRH agonist for a longer time to make them menopausal. So they may require it for 4 weeks, 5 weeks, but eventually they will become menopausal. Otherwise, we stop the treatment and change the protocol or change the action. But the reason for giving the agonist, now coming back to this discussion about the long protocol, the reason for giving the agonist is we don't want natural hormones to interfere with our IVF treatment. So when we deplete natural hormones and then start fresh with a high dose of FSH, we are aiming to recruit 10 to 15 eggs, and we are aiming to control how the eggs develop and when they are going to be ready. And by depleting the LH from the pituitary with this GnRH agonist, we have stopped the ability of your body to respond naturally to the estrogen which is produced by the follicle to cause inadvertent ovulation before the woman reaches egg collection. Because if you don't deplete and the LH is produced from the pituitary, it will result in ovulation in the middle of the cycle as soon as the follicle is ready because of the high estrogen levels before she reaches egg collection. So depletion of FSH and LH is necessary, because then we can plan with just giving FSH and there being no LH in the body to allow the follicle to grow as per our requirement, as per our size, and then only allow ovulation to take place with the trigger injection of HCG, which is a similar molecule to your natural LH. Okay. So that is what is happening with the long protocol. So that is the long protocol. I explained to you why it is done, how it is done, and we do know that it takes longer to respond. So Michelle, is everything clear, and are you hearing it properly?
Yeah, fine.
Okay, we are continuing now. Okay. So the next one is the antagonist protocol. So once this molecule was discovered, the GnRH antagonist was discovered, the GnRH antagonist completely changed the game, and things become much easier with the antagonist. Why and how? So basically with the GnRH antagonist, we are able to start stimulation on the first 3 days of the cycle straight away with the dose of medication which we feel is required. So the duration is shorter. And we start the GnRH antagonist in 2 ways. One is you can either start it straight away on day 6, or you can start when the lead follicle is more than 13-14 millimeter, which is what we used to do previously. But now we have switched to starting it on day 6. And the ESHRE guideline says that starting it on day 6 or starting it after the lead follicle is more than 14 millimeter, both have similar success rates. It's not that one is better.
So I'm interrupted. I remember when we used to wait for the follicle to
Yeah.
get to 12, 13 and then start.
Yeah, so ESHRE guideline says that starting on day 6 or starting when the lead follicle is more than 14, both are equally good. That's not an issue at all to influence the success rate. So that practice is fine either way. And the reason for starting this antagonist on the 6th day is now this antagonist works in a different way to the agonist. Now we have not depleted the pituitary of the naturally produced LH and FSH. So if we wouldn't have started this antagonist molecule or ganirelix, what would have happened is come day 9, day 10, we would find that the follicles will have triggered the release of natural LH. And it does happen that some women may ovulate before they reach egg collection. And to stop it from happening, you are starting the antagonist. Now, what does the antagonist do? Antagonist is a molecule which will go and fix to the same GnRH receptors in the pituitary. But instead of depleting the natural FSH LH, it doesn't deplete. The pituitary has the store of FSH LH. It will just stop the release. So it is a clever molecule. It will say that I won't allow you to dry out. I will just stop the release. So it's like locking the door, but allowing the contents to be securely inside. Okay. So it is taken daily in the case of ganirelix. And when we are ready for egg collection, we give HCG from outside, and that will stimulate the triggering of or release of eggs. Now, because we have not depleted the pituitary of all the natural LH and FSH with the antagonist, there is a storage of natural LH and FSH which is available in the pituitary, which may not be used if we are giving HCG trigger or OB trial trigger. But we have an option that if we want, we can make that FSH-LH release from the pituitary as a trigger by giving high amount of agonist. So when we give a GnRH agonist to trigger the release of eggs in a short protocol, it will displace the antagonist from the receptor. So it will kick out the antagonist molecule because we are giving in high doses, and this agonist will now stick to the receptor in the pituitary, and it will empty the pituitary of the LH. And when it empties the pituitary of the natural LH, that natural LH will act as a trigger to release the eggs or to cause ovulation in the follicles which are created with this FSH which we have provided from outside. So basically, we are just using the natural LH when we are giving an agonist trigger. Now, why is it any different and why is it any better than the HCG which we are giving in the form of OB-trial? HCG has a half-life of 7 days. LH, which is naturally produced, has a half-life of only 24 hours or 48 hours. So the advantage is that the HCG is like adding fuel to fire. So when you give a HCG trigger with someone who is hyperstimulating, the HCG molecule will persist in the bloodstream for up to 7 days or even longer, and it will be adding fuel to fire to perpetrate the hyperstimulation process happening in the background rather than calming down. So technically it will do the job, but because it is staying in the blood, it is going to keep causing more bloating and other side effects with hyperstimulation, as opposed to the agonist trigger releasing LH, and that LH molecule which will be in the blood only for 24 to 48 hours, and it will disappear because that's only its half-life. And then because it is there in the blood for lesser time, it is not going to cause more severe hyperstimulation. Okay, so that is the reason for giving the agonist trigger. Now, when we do the agonist trigger, why are there some cases where we'll give the HCG injection? Why are there some cases where we are asked to give estrogen tablets? Because evidence has shown that the HCG molecule is required in the blood for implantation, and results are better with HCG compared to agonist. There were some research which was showing that. But by giving estrogen supplementation, or sometimes the patients are given the trigger, the HCG injection after they have done egg collection. That is just to give additional luteal phase support to improve the probability of conception in patients of hyperstimulation who will be having transfer because they did not necessarily hyperstimulate, or they were clinically deemed well enough to consider an embryo transfer. And then to give them additional benefit, we give the estrogen tablets and the HCG injection in the luteal phase, but not as a trigger. Okay, so this is the concept which you needed to understand. And now if anybody wants to visit, they can visit again. Okay, so time of starting the antagonist, so the H3 guideline says day 6 or 14 size, anything is okay. So ideally starting on day 6 is better because there is no confusion there. Only in cases where the 14 millimeter size is going to be achieved on the 7th day or 8th day, you may save on 1 or 2 injections. But practically, you're trying to save injections when you may as well blanketly start, because not everyone is going to take longer to respond other than poor responders. So how will we decide which patient, which protocol is better? Look at evidence for high responders, normal responders, or poor responders. So generally, we can divide the patients into these 3 strata. So when long, when short is what the question is. So now this will give us information on why we are doing which protocol in which case. Okay. So with a high responder, the evidence has shown that GnRH antagonist is recommended for PCOS women with regards to improved safety and equal efficacy. So there is a strong evidence for that. So with high responders like women with PCOS, you will do the antagonist protocol, and that's why for all PCOS women, unless there is any issue or there is any background endometriosis or any other reason, we would do the short protocol because the evidence is overwhelmingly in that favor. And similarly, evidence is also for using Menopur in PCOS patients, and that's why we prefer to use Menopur with high responders or women with PCOS, because it is considered to be better than Gonal-F. GnRH antagonist protocol is recommended for predicted high responders with regards to improved safety and equal efficacy. So high responder does not always mean PCOS. There may be women with a normal AMH who may be low BMI, and sometimes these women may behave like a PCOS when you start stimulation because they start over responding. So they technically are a high responder. That does not always mean that their AMH is going to be high or they are going to be PCO. Even low BMI patients sometimes over respond. So they may also be called as a high responder. So the short protocol is again better in such cases. So sometimes you may see normal BMI, young woman, and you may see that there is no PCO, but we may still start on a short protocol because we feel that it will be beneficial. So that's how it will work out. So GnRH antagonist is recommended for predicted high responders. However, if GnRH agonist protocols are used, okay. So in some cases, say we have a woman who has had an endometriotic cyst removed, or she has a background of endometriosis, and she also has polycystic ovaries, and we want to do IVF treatment. It is always a catch-22 situation where we think the short protocol is better. But if you want to give the GnRH agonist protocol to that woman, then we can consider doing that, because if we give a lesser dose of GnRH, if we give a lesser dose of Gonal-f, then that can still do the job with the long protocol, because in such cases, giving the agonist is beneficial because it helps suppress the endometriosis. But with agonist protocol, because we have already depleted the pituitary of FSH and LH, the trigger will always be ovitriol. You can't have an option of agonist trigger because she is already downregulated. So it's not an option. So in that case, we'll need to freeze the embryos. If we are doing a agonist protocol, somebody is hyperstimulated, we are worried about it, then we will freeze the embryos. So normal responder, it has been shown from evidence that there are comparable live birth rates with antagonist and agonist. So it's so now the antagonist protocol is being used for more than 20 years. They have found that the live birth rates with both protocols are similar. But the risk of hyperstimulation is lesser with the short protocol. So generally, now the consensus from ESHRE is that the antagonist protocol is recommended for normal responder women with regards to improved safety. So that is their strong evidence-based recommendation. Though we do a mix of both, but technically, I think going forward, if we are following the ESHRE guideline, then we should have a low threshold to do the short protocol for even normal responder women, which means giving them norethistone and things like that. So these things you can discuss with Dr. Jacob again during your facilitatory meeting about how it works out best for scheduling of treatment. But that's why we do the long protocol, because we feel that scheduling treatment is slightly easier with the long protocol compared to the short. So poor responder, the consensus is that that the long protocol or the short protocol have equal efficacy for a poor responder. So initially we used to think that with a poor responder, short protocol is better, but now the evidence from ESHRE says that it is similar. It's not that one is better than the other, but generally if one is not better than the other, then why we are giving medication extra for 4 weeks? We may as well give it for 10 days, because the advantage of the short protocol is that less medication is required, shorter duration, and efficacy is same. So we tend to use the short protocol, and it has also been said in ESHRE guideline that 300 units is the maximum. We end up giving 450. So it's not that 450 is better than 300. So there is a lot of discussion sometimes. Oh, you gave 300, but I think she needs 375. Oh, we have written 375, but the patient is saying she wants 450 because the doctor said 450. But anything above 300 or 300 or 375, 450 is not going to change the response by much. So technically 450 is not better than 300, or it's not better than 375. So these things are very trivial in the sense evidence has already shown that any medication dose above 300 is not going to improve the response once it has reached the threshold of 300. We do give 375, 450 because we are in a habit of doing it. It's a process. And technically, not just us, quite a few units will give 450. But the evidence is that anything 300 and above will not make much difference, even in poor responders. So that is what the guideline says. Okay, overall antagonist protocol recommended over the agonist protocol given comparable efficacy and higher safety in the general population. In PCOS, antagonist protocol is better for the reasons we discussed, that lesser chance of hyperstimulation with the antagonist protocol. For triggering, GnRH agonist trigger is recommended for final oocyte maturation in women with OHSS, which is only possible with short protocol. The freeze-all strategy recommended to eliminate the risk of late onset OHSS and is applicable in both GnRH agonist and antagonist protocol. Now, what is late onset OHSS? So This is a good concept to understand. So you may find that somebody has had egg collection. Say hypothetically, we got 18 or 19 eggs, say 19 eggs. It was a short protocol. We gave the agonist trigger. So we did everything right. The woman is well on the 5th day, and even the day 3 OHSS check, she is well. Her bloods are normal. Everything is perfect. With 19 eggs, we decided that she is well enough. Everything is normal. Let's go ahead and do the embryo transfer. Because she is well. That's why she comes to see the doctor to determine that. But sometimes we still make decision that in some cases we would freeze the embryos even though the woman may be well. Now, like this woman we have seen today in the clinic, the one I will not tell the name because we are recording. So yeah, so this woman who is on the long protocol, who is not technically hyperstimulation, but she has 50 follicles, but not all follicles are growing. So if she is well, and say we transfer the embryo. Now the OV trial is in the system for 7 days. So it may go out of the system in 7 days time. But after 7 days, when the embryo will implant, the implanted embryo will start now producing HCG molecule. So OV trial you are giving from outside. The pregnancy is producing its natural HCG. And that HCG is what you are going to detect in a pregnancy test another 10 days down the line. And that HCG will now act on the ovaries to create a delayed hyperstimulation phenomenon. Because it is pumping FCG in a high number into the blood as the pregnancy grows. And that is going to make the woman unwell with features of secondary hyperstimulation, which will continue up to 9, 10, 11, 12 weeks of pregnancy before it settles down. So technically, even though she is well, she may still develop hyperstimulation after the 5th, 6th week of pregnancy. And that is because of what we call a secondary hyperstimulation. So sometimes freezing the embryos, even though the woman is okay, is not certainly a bad decision, because you are not going to be able to have a crystal ball in front of you to decide which woman is going to become unwell with secondary hyperstimulation. So there is nothing right and wrong here. What clinically you feel right, you do. So current practical recommendation, GnRH antagonists have rendered the IVF treatment cycle shorter. So it saves time, less side effects compared to agonist, less consumption of gonadotropin. So you'll save on money, less risk of OHSS because we have the agonist trigger. So less risk of OHSS. And sorry. And the live birth is as good as in the GnRH agonist protocol. So technically, if it has not made any changes to the final outcome, then why do we need to change something which is working well? Okay. Any questions? Or all questions solved?
And about the new shot protocol, the whole northeastern thing, how does that all work?
Yes, so I have read about that. So in the same guideline, it mentions that giving OC pill will reduce the efficacy of stimulation with the short protocol. So it will have a detrimental outcome. And that is the reason why they have started giving norethistron, because norethistron has not been, or progesterone has not been shown to have any detrimental effect on cycle stimulation, like how it was seen with OCP. So they have also been in line with the protocol. They must have also thought about it that the OCP is probably having detrimental effect as per the guideline. I don't know whether they did an audit on the cases or the cases which were sent to us, but norethistron will not have a detrimental effect on stimulation or the outcome. So I think doing norethistron is the right thing to do. And it has no negative effect. So you can tell the patient that it's not going to influence the outcome. It is not going to influence the stimulation. Yeah, it doesn't influence.
How does it work? It's through what?
No, it is scheduling.
It's just for time.
Yes, scheduling. It's not for any benefit. It is for scheduling so that you spend less Saturdays here.
What more about it? Yeah, I don't think it's falling like that. That's to do with this. Yeah.
Yeah, so it is good. So it's fine. Good. And they are following what is right. Okay, and any other question?
Well, I would just like to look very basic, like sometimes a patient would say, so why am I long then? And rather than me go, well, the efficacy, you know, the effective, just who typically longs, well, it used to be, well, shorts for the older ladies, low AMH, longs were your, well, PCO's short now, don't we? We used to do PCOs for long. So who,
No, I tell the patient if there is no reason, I tell the patient it is because it is easy to schedule your transfer.
so
You don't need to give answers which are not required to answer. You just tell them straightforward. It is easy to schedule your treatment.
yeah.
Nobody will ask you anything. If you try to negotiate that, if you are very straightforward in your answer, they will agree to it. Nobody says disagrees to it generally.
I always say neither is better or the other. The doctor looks at your results and your things
Yeah.
and they decide
Well,
which is best for you.
I don't want to say that, but there is a reason, some people do have long and
But
some people have short,
generally-
so I want to know why they choose long. and
Generally,
short.
when they are booked, we tell them why. At
No,
least I tell them why. I say that I will book you for this protocol because I think this is better for you.
and that's all you give. So what would, if, I'm
If they ask me the question why, then I will tell them. One is, if it is long protocol, I'll tell them scheduling will be easier because in your case, your period is not this way, that way. I'll tell them some reason.
Yeah.
Sometimes if it is obvious, like polycystic ovaries or a poor responder or a high responder, and I feel that they need short, then I tell them because you are a low egg reserve or your PCO, short protocol is
So
better.
PCO, low egg reserves, short, typically.
Yeah. So long and short both are equal in a poor responder. Then why are we giving more days or
Yeah,
drugs? We better
yeah,
do a
yeah.
short. That's how it will work.
Low and short, same, and corresponding.
Okay.
In the long protocols, you know, when we're checking them on day 21, checking they've ovulated, and you mentioned that if they haven't ovulated, did you say that we should be waiting for 7 days after ovulation? Because sometimes we don't know, do we? So sometimes we see them on day 21, we'll check them again in a few days. Have they now ovulated? Yeah, okay, we'll give them a Prostap or start buserelin. But I think one of the questions that crops up all the time is, shouldn't we be waiting for 7 days after that ovulation, or are you happy?
Yes.
Are we fine to give it at the time of ovulation?
So basically, we are doing this day 21 only in someone who has a regular cycle. So say if somebody has a regular 28-day cycle, I'm expecting that when I'm doing a day 21 scan, it will be 7 days after ovulation, which has happened around day 14. And I will be able to start if I see evidence of corpus luteum. But there will be some women who have a 28-day cycle where the corpus luteum will not be very obvious and we will not see any evidence or any follicle either growing. In which case we would still give Prostap because there is nothing else we could do. But we are saying that in case if we do a scan on day 21 and we see a follicle of say size 13 or 14, then in that case we have to give it another 2-3 days and scan her again to find out whether that is a pre-ovulative follicle or it is a cyst. But if there is no evidence of any follicular activity on day 21, then you are okay to give Prostap.
Okay. Yeah.
Does it answer your question?
Yeah.
Because
I
that
think
scanning after 3-4 days after day 21 is only in cases where we are seeing a cyst or a follicle, and then we don't know with that just one scan whether she has ovulated or not, because we are seeing a follicle, and if she has not ovulated, then it would be wrong to give the Prostap injection or buserelin because that will cause her to ovulate and not downregulate.
and
No,
that's
I-
when they can get cysts
Okay.
afterwards then, yeah.
So I know, well, I think Michelle sort of as well, that for instance, Helen and Mr. Bono particularly used to say you had to give Prostap 7 days after ovulation. So let's say we saw them on day 21, there was still a follicle there. Day 23, we saw them and the follicle had gone. Then we would have to then wait 7 days to give the Prostap.
We don't need to give wait
No, so
7
that's
days.
that's what Mr. De Bono and Helen used to
Oh,
say.
okay.
But our point as nurses was, well, I might see him on day 21. There might not be a follicle there, but it might have only gone yesterday.
Yeah,
That's the point. Yeah, yeah.
So, yeah, so for practical purposes, if we are not seeing a follicle on day 21, we are assuming things are
It's-
either
yeah.
quiet or she has ovulated.
So
and
on the
it-
day 23, when we saw it on day 21, but we don't see it on 23, we could just give it on
Yeah,
day
yeah,
23.
yeah.
Right, yeah.
Yeah, you don't need to wait any longer because it is not going to give any more
Yeah,
help.
they did use to make as well.
Yeah, because when I've been working since the last 10 years, I don't think we waited for 7 days after day 23 when I have been working.
No,
Don't-
we did,
Did-
definitely.
Just-
Mr.
I think it
DeBarno.
just depended who we asked, didn't it? It's one of those that
Oh, okay, okay.
now we know, now we've sort of gone through this. I think it's probably helpful in us understanding that as well. That's good.
Yeah, so was it clear or did you know all these concepts before?
Well, Mr. Bonner, I've been here for 2 years, but Mr. Bonner was quite definite that we did that. Obviously, Helen.
No. Concepts about the short and the long
Oh,
protocol.
no, sorry, I thought you meant day 21.
No, yeah.
Yeah,
No,
that's
did you all know about all this which we discussed today or did you
I
not
used to
know?
look at when I was doing prescribing, didn't I?
Yeah, no,
so-
but did you know or did you not know?
It's kind of consolidated it for.
Yeah, yeah.
It's made it make
And the
more
whole
sense.
sterling trigger thing, yeah, I didn't really get it. I never really looked up on that.
No,
You
but
should have
that-
added on to it.
that
We did do
makes
issue for
sense.
years, didn't we? We never did the issue.
But now, because you know why it is done, you will remember it because you know why it is done. It's not that you are doing something because I, as a doctor, am telling you to do something. You will do it because you feel that this is going to benefit the woman.
Yeah.
Yeah. So, any other questions, Michelle?
I don't think so yet, but I'm sure I will do when I start thinking about comparing buserelin and Orbitrel trigger, which might come into my assignment.
Yeah, no problem. But then now this is
One for you to do, Michelle, actually.
Well, yeah, it might have just switched my mind really. I might just all my notes that I've just made might just be written out into a load of pasted words. It's good.
So when we stop this recording, it will get saved onto this chat. And then we can download it and save it on our hard drive of Yorkshire Fertility. So that way, what will happen is, say, in a year's time, if somebody wants to visit this again, because they want to refresh their knowledge about short, long, or have some doubt, then they can visit the recording again and understand, or say a new nurse joins and she wants to know why we are doing what we are doing. Then that nurse can just listen to the recording and she will know. So probably because the recording expires in 30 days or 2 months or 3 months, something like that. So we have to save that. The recording gets saved at the moment for next few days. But unless we save it on the hard drive, it will not become immortal. Okay.
So I'm not until Wednesday, but I'll save it if you want when I get in.
So will you be able to save it onto the hard drive, network drive?
Yeah, I'll do
Okay,
it on
I will allow-
Wednesday.
because you know that Meditex, I have saved it on the hard drive. So now you can use it, the same module for new people.
Yeah.
Yeah.
Thank
Okay.
you. That was really good.
Thank you. Thank you very much. Bye. Bye.
Bye.
Bye.